Good morning, guys. I hope things are fine and you're enjoying your GI block, and it's a very interesting area of learning and practice, and so many new infos and real life situations. Uh, I'm talking about a subject, according to my personal description, one of the most difficult topic for teaching, because so many concepts, it's all about concepts. It's not memorization. And if you understand, you're done. It's very easy to understand, but very difficult to teach. And without any word, I can say that this lecture is the mother of GI. You know this, you know everything. After finishing this lecture, you are, in my way of thinking, you are 90% done. Remaining 10% is just plugging in different things because your main concept is over. But if you have glitches, please don't go away. Stay connected. We'll try our best, because this is a subject which has to be learned in small discussions. And I encourage you, when you'll be going to your labs, spend time with your peer tutors. They will try to help you. I know it's not easy, but when you work together, you learn it. As this is a complex topic, so I will not be giving you full detail today this morning. I will try to go over the concepts, and then I will connect it to the clinical part. That what is the application of this, why we need to learn it, and how it really affects the human beings. And this is one of the major thing, because this peritoneum leads to a life threatening condition that is called peritonitis. And peritonitis, in good centers of this world, still it's a questionable topic, survival or no survival. So it's that complex type of entity. So let's try, guys. It's very simple. It's very simple, but to a certain extent, it's difficult because it's challenging. It's not an easy concept. So now, before starting, there are few lines. Let me read these two slides for you. Usually, I don't prefer to read slides, but today I have to read these two because they are about certain terminology. So, it is the largest serous membrane. Primarily, it's mesothelium in the body and a complex in its arrangement. It lines the inside of my abdomen and it reflects onto the abdominal viscera. And I'm using a term, it consists of two layers. Actually, this is not two layers, it's one layer structure. But it folds on itself, so it gives a pseudo appearance of two layers. But actually, it's one layer which folds on itself, so we think, oh, these are two layers. But actually, this is one layer. The layer which go close to my organ, I call it visceral layer. And the layer which go close to my body cavity, we call it parietal layer. And in between this visceral and parietal, we had a fluid, we call it peritoneal fluid. And that fluid has a lubrication effect, and it helps my organ during the various activities, what you have learned so far during previous week, the peristalsis and everything. So all these movements has been facilitated by this fluid, and that is happening. And remember, this concept goes with the heart, this concept goes with my lungs. In the heart, we call this peritoneum as pericardium. In the lungs, we call this peritoneum as pleura. They are similar kind of structures, but the organization is very complex within GI. Other places, it's very simple, no rocket science. So now, my second line says the parietal peritoneum lines the abdominal walls. Parietal means walls, body cavities, and under surface of my diaphragm. So diaphragm is the superior limit. From the diaphragm to my pelvic cavity, the diaphragm, the visceral peritoneum covers the intraperitoneal organ. Now, I'm using a term intraperitoneal. Actually, there is nothing who is inside the peritoneum. Everything is outside the peritoneum, but for certain situation, we call someone as intraperitoneal. Actually, it's not. Why we call it? I'll be explaining, showing to you shortly. So in between in this space, the peritoneal cavity, and that contains a fluid. I talk about it. And it's a very small quantity, serous fluid. The third line says this fluid lubricates, we know it. I don't want to read it again. So now this line, if you don't read it, it's better. Because to explain it, I have to wait for long, not today. In males, it's a closed cavity. In females, it's an open cavity. That's a good point of discussion, but not today. It will increase the complexity of the subject, and I don't want to read it. Rather, when I'll upload it, this line will not be there. Okay, now the terminology. We need to understand the terminology. So what are the terminologies? So before we go, the peritoneum is like a balloon. Everything is about a balloon. And today we'll be learning about this balloon. Now, what happens? My balloon, I don't see any person will not understand what it is. Now, why I'm bringing a balloon here? Same balloon, I change the color. And down you can see, I'm showing you something. This I call it as an organ. One of the organ. It could be liver, could be stomach, could be intestine, any part of intestine. So what happens? See how this balloon and this brick is important for me and you. So now, the terminology. What terminology we need to know? Mesentery. What is a mesentery? A double layer of peritoneum, which enclose an organ and it connects to the posterior abdominal wall. What's that? We don't understand. Another term, omentum. I'm sure Dr. Atif has talked about omentum when he must be explaining to you about stomach. So it's again I'm saying it's double layer of peritoneum, extend from the stomach to other organs. So same two layers. If it extends from my posterior abdominal wall, I call it mesentery. When I take it away from the stomach, I call it omentum. And then when I take it away from the anterior wall, so then I call it peritoneal ligament. All double layers of the peritoneum, not called mesentery or omentum, if they extend between organs or between the organs and the anterior abdominal wall. Let's stop. Two layers of peritoneum, extension of peritoneum from posterior wall to an organ. We call it mesentery. These two layers, let's say it reaches to the stomach. From stomach, it extends to some other organ. We call it now omentum. Same thing, only change of name. And now, if we derive these two layers from the anterior abdominal wall or between two organs, and these two organs should be other than stomach, between two organs. Now we call it a ligament. This ligament is a different ligament than the ligaments which we learn during MSK. Those ligaments were strong. Their job was some protection, there were some ropes. They were tying around the joints. But here the situation is entirely different. I hope I'm clear. Any ambiguity with this concept? What is mesentery? What is omentum? And what is a peritoneal ligament? It should be clear. Ligament, anterior wall, or from another organ. Mesentery, posterior wall. And omentum from the stomach, anything from the stomach to any other organ. You may come up with, doctor, you're saying before, between organ and organ, you call it ligament, but now I'm saying precisely from stomach to another organ, the same ligament, will not call it ligament, we'll call it omentum. But if it's, say, between liver and duodenum, between spleen and blah, blah, so we have a different, we call it a ligament. But from stomach, it's called omentum. And if you are done with these three terms, you have done 50% of understanding. I told you 99% of your GI is peritoneum. Out of this 99, if you know these three terms, you are done with 50%. And now you have to learn another 50% out of 99. So now, peritoneal recess. What is that? A recess is a place, some hideout, something in between. How? Let me use this flag. So now you can see that the surface, and now something is, it folds on itself and you cannot see it. There is some potential space. There is some area behind. So we call it a recess, which is not accessible in direct vision. Some hideout, something behind. Then, what is that? Intraperitoneal organ. I don't want to read it, I will show it. Then, retroperitoneal organ, I will show it. And the last, extraperitoneal organ, I will show it. How? My next slide will show it to you. First, look at it. Same balloon and an organ. This is an organ, this is a balloon. Now what happens? Guys, today's lecture is all about seeing things. Don't read anything, just see it. Look at it. Is this round circle, is this organ, is really inside this balloon? Say yes or no. Why no? Because it has pulled a part of it. It has pulled a part of it. So now, let's say this is gut, because we are in GI, is all about gut. And so now, this is an example of an intraperitoneal organ. If an organ drags the peritoneum, so the peritoneum, which is here, which is close to my organ, I have all the rights to call it as the visceral layer. And this peritoneum, this is the same peritoneum which is lining my body cavities. That's the parietal peritoneum. And this is somewhere my posterior abdominal wall. So it drags two layers of parietal peritoneum and it goes all the way. So that is an example of a mesentery. If it was coming from anterior abdominal wall, I was calling it as a ligament. If it is extending, let's say this is stomach. If it is extending down below, not going to anything but just going down, I will be calling it as omentum. So the same concept. Are we clear? So in the beginning, our peritoneal cavity was like a balloon. Then organs start growing. They start coming from different direction. And they invade. And a time reaches, my whole peritoneal cavity was squeezed, sandwiched. And I cannot see a big balloon there. If you open up an abdomen, when you visit cadavers, you will not find a big space because all the organ has grown in size. So the space between is almost gone. I'll be showing you today, don't worry for that. So this basic concept is, you have seen now what is intraperitoneal organ. Is it inside the peritoneum? Is it inside this balloon? No. But I call it intraperitoneal organ because it drags a mesentery. Why it need a mesentery? It needs a mesentery for, it needs a ligament for, it needs an omentum for getting its blood supplies. Every living organ has the right to have its arterial supply, venous drainage, lymphatics, and nerve supply. And they all reach to this organ or further parts of this organ through this double layer of peritoneum, that I call it here as the mesentery. Are we good? Now, so examples have been given: small intestine, spleen, liver, etc. So they go like that. And this is, as I told you, the part of the peritoneum which is adherent to the surface of the organ, that we call it as visceral. When you'll go to the lab, you'll be seeing an organ sitting there, I'm sure this week, liver. If you inspect this liver, you'll surprised to see its surface was shining. This is not a paint. Actually, this is the visceral peritoneum, which adheres to it. If you can peel it off, if you peel it off, this will go and you can see the rough surface of the organ. So this visceral layer of my peritoneum, that will be shining. Even if you can see the cadavers will be there and you can inspect everything what is happening. Now, we said what is towards my body wall, I call it parietal peritoneum, and what is towards my organ, I call it visceral peritoneum. This is in between a peritoneal cavity. It's very big in the beginning, but with the time it will go off. It will not disappear, but it will become minimal. And now, this fold of peritoneum, which was being dragged, that we call it as mesentery. Are we good? Any problem so far? Now, this is my anterior abdominal wall. And this is my posterior abdominal wall. So everything is in between. Now, this is my diaphragm, upper limit of my GI, abdominal cavity, the diaphragm. This is my aorta. And this aorta we all know from where it's coming. Abdomen, in the abdomen, so I call it abdominal aorta. When we'll be in CVP, we'll call it thoracic aorta. When we'll go close to the heart, I will call it ascending aorta, arch of aorta, descending aorta. When it reaches to the fourth lumbar vertebrae, I will be calling it into common iliacs when it bifurcates. When it is going to my lower limb, I will be calling it femoral artery. When it will be going to my leg region, I will be calling it popliteal artery. Same goes with the upper limb. So this is aorta, which is present in my abdomen. I call it here as abdominal aorta, and this abdominal aorta sends an artery, and every organ to survive needs oxygen, nutrition. So that's a branch of the abdominal aorta. It could be any branch. I'm not specific which part of the gut you're looking at. This is a generalized understanding. And once you get this understanding, then it will not be difficult for you that you can say this is celiac trunk or superior mesenteric or inferior mesenteric, which artery or which branches. Are we good? Okay. So now, situation is a little bit complex. What happens to my balloon? Balloon has been dented because different organs are approaching from different directions. And now we give them names. An organ is here. What is specific with this organ? It's covered by peritoneum from 1 to 3 surfaces. But the posterior wall is free. It adheres with the posterior abdominal wall. So that's an example of retroperitoneal organ. And the examples of retroperitoneal organs has been given here. So who are the organs which are retroperitoneal? So organ not completely doesn't have a mesentery, but it has been covered from front, but the back is not covered. But 3 sides. It's covered from 3 sides. I call it retroperitoneal. And when I go down, where is my down? Here. When I go down, what situation comes here? I have certain organs which are living in my pelvic cavity. And who are those organs? Urinary bladder, uterus, rectum. Not all of them. I'm using an example of urinary bladder right now. It's only covered from one surface of it. So now, this is an example of what? Extra peritoneal organ. Let's recap. Organ from one surface, extraperitoneal. Organ covered from three surfaces, retroperitoneal. Organ who drags the mesentery, intraperitoneal. Are we good? So, if you know this much, you have learned 70% of 99%. 70% is done. Now, so it's easy, but not that easy. Basically, it's a concept. If this concept, you're good with this concept, now I'm sure life will become way easy. You need not to memorize things. If you conceptualize stuff and then you can imagine it, there is no one who can stop you from learning it. So now let's look at it. This is any other organ is same duplication of the idea just to reinforce. Look what happens. My visceral peritoneum covers it around, goes to posterior abdominal wall. What we should be calling it? Intraperitoneal. Are we good? So this is an example of intraperitoneal. Any doubt? It's coming from posterior abdominal wall. Now, same organ, I'm calling it retroperitoneal. You can see it. Covered from three sides. Are we good? So this example, and it adheres posteriorly with what? Where is posterior? This is posterior. It adheres posteriorly with what? With posterior abdominal wall. This is retroperitoneal organ. Examples are my ascending colon, my descending colon, and other organs, but these are very simple tubes. Okay, third example. An organ and peritoneum just goes over in contact with only one surface of this organ. So this we call it as extraperitoneal. Are we good now? What is intraperitoneal? What is extraperitoneal? And what is retroperitoneal? Any ambiguity? Any person who don't understand this concept? Sure? Now, we know about it. We talk about it. This is posterior wall. These are the parietal and visceral layer of the peritoneum. This is an organ. Cavity, mesentery, nothing new. We can see how aorta and my inferior vena cava, let me use this word here, are getting or receiving their supplies to this organ. Same concept. This is the concept of a mesentery. Are we fine? Same concept is applicable with ligament, with omentum. Fine? Now, let's another concept. You must have been explained greater sac and lesser sac. What are these? Do you agree this is a sac? No rocket science, this is just a sac. Sac means something close. A kiss. You tie its mouth, it's a sac. Now, this sac undergoes some changes. We pinch at one place, it's been pinched here. So now, one part is big and one part is small. The big part I call it greater sac. The small part I call it lesser sac. Any rocket science? A sac, I pinch it, let's say it's a balloon. You pinch it in between your hand, one small part of balloon and one big part of balloon. And now this red circle is an opening. I have a name to it. I call it epiploic foramina or omental foramina. Are we clear? So it is a gateway between my greater sac and lesser sac. And this arrow indicates you are going through greater sac to lesser sac. And why these sacs has been created, organs were developing from different sides. So the peritoneum was squeezed between. And now there was only one gateway to enter that part of the peritoneum, which is behind my stomach. And we call it lesser sac. You must have been taught this epiploic foramina have very high clinical values. When we are doing the resection means surgery, when we are removing it, when we are doing what? When we are removing gallbladder. What is gallbladder? Marara. When we are working on that, fair enough chance we might cause a damage to hepatic artery. If hepatic artery damages, you have not seen it. I have seen it many times. It bleeds like a fountain. It's a small artery, but when it bleeds, I have seen it bleeding. It paints faces, it paints everything. That high pressure. Surgeon, what he does, if he's smart enough, surgery is all about safety. If you're smart enough, you know how to handle. Sitting ideally, you can talk blah 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 blah. But once in real game, you can say why. When you're watching your game football, you're really angry. Why this player is not able to do this? Why he cannot hit in the thing? Is he blind? You shout. You're angry because you love him. You want your team to win. But the one who's playing, he knows how much difficult it is. How strong are the opponents? He has to dodge, he has to play. So surgeon is the one who knows how to handle a situation. Otherwise, everybody can be a surgeon. So a smart surgeon, he inserts his finger in this epiploic foramina, and just this finger, index finger and the thumb, you pinch. What? You are pinching hepatic artery. Anteriorly, you are in between. Within your thumb and finger, you are holding hepatic artery. And this procedure, when you're doing it, it's famous with the name of Pringle maneuver. We all know Pringle chips. We remember from our early childhood. We love Pringles. So this Pringle is here. This is the Pringle maneuver when we put the finger through this epiploic foramina. So now in front of my index finger, I am having very important structures. They run in the free edge. I don't want to make it complicated here. Just simply, you put your finger, you can clasp, you can hold the hepatic artery between your thumb and index finger, and you just keep it holding till you repair the part which has been punctured, which has been damaged. Rest is fine. Are we good? So, I hope the concept of greater sac and lesser sac epiploic foramina have some clarity in your minds? Yes or no? Any rocket science? Guys, see, it's all about game. We are playing with a balloon since morning. So I call it lesser sac, and we know about epiploic foramina, we know about greater sac. Now let's bring it in our concepts. Let's make it more meaningful. So now, this is me. I'm with a big balloon. I'm holding it. My hands are holding it. And away from me is the anterior side, and I'm on the posterior side. Just look at me and my hand. What I'll do next. So now, I start pushing my fist into this balloon. I start pushing, and I keep on pushing. I'm holding a big balloon, I'm pushing it inside. When I'm pushing it, can you see that? This was one sac. Now, a big sac and a small sac. Are we good? So we are seeing what? Same concept. Greater sac and lesser sac. And between my nose and my fist, this is my epiploic foramina. And between my hand, I will show it to you what I'm holding in my hand. Are we good so far? Perfect. This arrow indicates, guys, in older books you may find foramen of Winslow. Don't be surprised, what the hell is this? Foramen Winslow or epiploic foramina or omental foramina, same word, different names. So this is epiploic foramina. And look, I'm holding 3 markers in my hand. One is blue, one is red, and one is green. So what are these? Thank you very much. So these are common bile duct. Green is common bile duct. Blue is portal vein, and red is hepatic artery. And place where my head is, that's the place where I have inferior vena cava. Above to it, I have liver. So, if somebody asks you in the exam, the boundaries of epiploic foramina, you can smartly write anteriorly in the free edge of lesser omentum, I have portal vein, hepatic artery, common bile duct. Behind, I have inferior vena cava. Superiorly, I have part of the liver. I give it a name. And below, I have duodenum. Period. We are done. These are the boundaries of my epiploic foramen. I have not seen any exam of GI where somebody is not asking about epiploic foramen. Be good with that. You'll find it. Are we fine? Red box is showing you down. Now, same concept. Let's make it more closer to reality. Are we fine so far? Any new thing? Alhamdulillah. So now everybody can understand this is greater sac, this is lesser sac. This is stomach is the one who was basically pushing it in. Why? Guys, to understand peritoneum, you need to have very good understanding of developmental part. Stick to Paul's lectures, where he'll be talking about rotation of the stomach, rotation of the gut, herniation, physiological herniation, and all that. Because of this rotation, the mesenteries, they fold on itself, and then we have this. This is the reality. Before we were playing a game, now I'm telling you what is the reality. So stomach is doing all these things. Because of that, these folds this recess has been created. Are we good? Now, this red arrow, epiploic foramina, nothing new. Now, same what I was holding in my hand. What I was holding in my hand, portal vein, I don't like to call, I call it CBD, common bile duct, and hepatic artery. Are we fine? So these three structures which I'm holding in my hand, and behind, inferior vena cava. What is this green thing? It's a partition. What is partition? You call it rough. You know, in your closets, in your home, you have shelves. So it's a divider. So it divides my abdominal cavity, an area above to it, and an area below to it. An area above to it, I call it supracolic compartment. An area below to it, I call it infracolic compartment. Are we good? So we have seen this green thing. What it is, I'll be explaining to you shortly. But this is a divider which divides my abdomen into two compartments. It lies horizontally. Above to it, I call it supracolic, and below to it, I call it infracolic. I have a series of a list of organs who lives in my supracolic compartment, and I have a list of organs who lives in my infracolic compartment. Only one structure which is passing through and through from this, that is my duodenum, the first part of my small intestine. Now, this is transverse mesocolon. What is that? mesentery of my transverse colon. I call it transverse mesocolon. Same mesentery. The mesentery which goes and encloses my transverse colon. So I can say now, transverse colon is an intraperitoneal organ. Now if I use this term, you know it. What is an intraperitoneal organ? Yes or no? So now, this is the one, this mesentery is the one which divides into supra and infracolic compartments. So let's put the organs here. This thing, this ovoid thing is my spleen. There is my pancreas. Are we good? Now, any question here so far? Anything new? Good. Now, this is a sagittal section. We all know what is sagittal. You cut someone in the midline and you're looking at different organs. On top, you can see the diaphragm. You can see the anterior abdominal wall. In the bottom, you can see this bone. This is my pubic symphysis. This one here is pubic symphysis. This is my liver. That's my diaphragm. This is my anterior abdominal wall. And this is my stomach, transverse colon, and loops of intestine. I'm not naming them jejunum, ileum, vice versa. And in the bottom, you're looking at urinary bladder. This is a male example. If it was a female, I could have put a uterus here also. This is the rectum, anal canal. Are we good? Now, let's label it. Anterior abdominal wall, diaphragm, pubic symphysis, we all know what is that. Stomach, transverse colon, urinary bladder, rectum. This is my abdominal aorta. These are its different branches. You're looking at the celiac trunk. You have learned about celiac trunk when you are learning about the blood supply of the stomach. It's important and we love it. You know what is the meaning of we love it. Now there is someone. Who's that? That's my pancreas. Who's that? Superior mesenteric. These are the different branches. Duodenum. What happened? All these organs, now you can see here, the different examples. You can see here very clearly. What are we looking at? Look at the peritoneum. I'm just showing you only from the front. This is the parietal peritoneum. This whole thing is the parietal peritoneum. Just follow my arrow. This whole thing is the parietal peritoneum. And now, this is a mesentery, which goes to my loops of small intestine. So this is mesentery. This is not decided yet because I have to put something more, but we know that this is the parietal peritoneum and this must be the visceral peritoneum. Now look at it. Something is going away from my stomach. Should we call it mesentery? Should we call it ligament? What should we call it? Omentum. Excellent. You guys are smart, mashallah. So let's label it. Then life will become easy. So you have seen the parietal peritoneum. You have seen the visceral peritoneum. Why visceral? It's covering my viscerals. And that's my peritoneal cavity. And this is what? Mesentery. Are we fine? There are so many mesenteries, but I've just labeled one. So don't ask that, is it only one mesentery? So you're looking at the coils of the ileum. Now, you can see that it's going dipping in between my bladder, urinary bladder. Gallbladder is also bladder. But when we use the term bladder, we mean urinary bladder. So between my urinary bladder and in front of my rectum, it's an example of a rhesus, a pouch between rectum and bladder. So rectovesical pouch. If this was a female, then I'll be having a pouch between rectum and uterus that is called rectovesical uterine pouch or pouch of Douglas, very famous. So much is connected to that, very important for female health. And then they also have rectovesical pouch, but male has only one pouch and female have two pouch. So this is my recto. So now you can see the example of a pouch or a recess. There are so many recesses we have. So basically this is what you can see, it's a space which is formed between the two structures, two organs. Are we good? Now let's fill it. So my peritoneal cavity is filled with the fluid. All the organs has invaded. And now this is my greater sac. Where is my lesser sac? I cannot see him. Can you see him now? The green thing? The green thing is my lesser sac. And when it extends from the stomach down, there are four layers. They blend and they become one. And this one hanging structure, we call it greater omentum. Because layers of the peritoneum, which are going away from my stomach, it's big. So I call it greater omentum. And if you see backwards, where? Here. From the stomach towards my liver. These two layers, I call it lesser omentum. So the two folds of peritoneum which are connecting liver to the stomach and duodenum, they are called lesser omentum. And this big apron which hangs downwards, it is called as greater omentum. So we have learned what is greater and lesser omentum, what is greater sac and lesser sac, what is mesentery, what is retroperitoneal, what is intraperitoneal, what is extraperitoneal. Are we good? Now, this is the easy part. Now let's bring a little more understanding, because we need to know it, guys. Patient will not walk to you like that. You cannot see this section. You always see what? Transverse sections. So CT images. So how we can interpret all those? Because in real life, we have to incorporate all those things. So now these are the just labels. We know where is the lesser omentum, where is the greater omentum. There is no rocket science here. Are we fine? Can I proceed further? These are more details, more supplies. Just you add on, you keep things fancy. Now, how I understand the same concept that was in a sagittal view, now it is a transverse view. Same organs. Obviously, it goes with different levels. Guys, in GI, sections, transverse sections is an important concept. You will be taught and you will be asked. With anatomage, with sections, you remember in MSK, I have shown you the sections, but you are not asked in the exam. You are shown. Why you are shown? So you understand today and tomorrow. There will be significant number of questions, especially in OSPE. They will be from these sections. And this is the mother of understanding of those sections. So this is 12th thoracic vertebrae level. I am just having a transverse section, a cut. And now the organs, what are visible to me, we can label them. There's no rocket science. Any problem with these labels? Good. We can see, we should be clear always, veins are on the right side. Liver is on the right side. Stomach is on the left side. This is the general rules. Spleen is where? On the left side. Don't make a major mistake when you are given these things. If you are clear, oh, liver is a big organ, the biggest organ in my body. Oh, it's always on right side. I'm not saying 100%. If I'm encountered with a patient who has situs inversus, like organs are put in a different direction, heart on right side, not on left side. All organs, I've seen some patients with this. And trust me, they were normal, like you. They didn't have any complaint. One of them came to me for what? Oh, doc, I cannot have babies. I'm married for last 5 years. I don't have babies. So it means everything is fine with him. Happily living his life. But when I was examining him, I found where the heart is, it's all opposite. But he didn't, alhamdulillah, he didn't have any problem. So don't think that someone has situs inversus, the organs are placed in different direction, oh, he'll be a dead man walking. No, that's not happening. So now we are good with these organs. So let's put the things here. Can you see that? How the parietal peritoneum and visceral peritoneum is being basically placed here. Same concept, only you're looking in the transverse section. Now, can you see here? I want you to be focused here a little bit. Let's label them. From the anterior abdominal wall to an organ, guys. Your word needed. Is it a mesentery? Is it a ligament? Is it an omentum? Ligament. Excellent. Let me use some laser pointer thing. Yeah, red is fine. So this is a ligament. Okay. From my stomach towards the liver, what is this? Omentum. Now between kidney and spleen, ligament. Excellent. So you guys are smart, mashallah. You guys are smart. That's why your class is very good. Very strong class. I like this class. So these are the labels. When it surrounds the organ, we call it visceral layer. When it goes to the body walls, who make the body wall? The ribs and the skin and all those things, anteriorly and posteriorly. So now the peritoneal cavity is being filled with the peritoneal fluid. And we can see every organ. Any problem? So let's fill up. Let's label the thing. We call it falciform ligament. We have greater sac. We have epiploic foramina. We know what are these organs. Guys, you can see that. In front, portal vein, hepatic artery, CBD, behind, inferior vena cava. So this must be what this should be. Lesser sac. And there is my epiploic foramina and all that. We talk about the boundaries of lesser sac. So this is the lesser sac. Are we good? So now these are the labels. These are the different arteries which run through different ligaments. So the ligament between the kidney and the stomach, the ligament between the spleen and the kidney, they have their names. There is another word used for the spleen, lean, and for the kidney, renal. So lienorenal means between kidney and spleen. Gastro word used for stomach, gastrosplenic. Okay? Even some books write gastrolineal. So there are different terminologies, but you should not be bothered with those. So you can see that basically these mesenteries, these ligaments, these omentums are used for the free passage of arteries and veins and nerves in between different organs. And that is the main concept which we need to understand. And the labeling is there. You can see that lineorenal means lean for spleen and renal for kidney, so lineorenal ligament. It's the communication between my spleen and kidney. Are we good? So guys, I stop here. The remaining part will be coming to you as an asynchronous lecture. Okay? So I have tried to give you the main basic concepts. But that's just the beginning. And I understand you should learn it nicely, spend time on that, and then you'll find everything good. I'm open to your questions.